Hey guys, we're gonna wait about a minute and then we'll get started. We'll just like get everybody come in and then we'll get started. Hey guys, we're gonna wait about a minute and then all right, I'm gonna get started. Today we have a very exciting call. Before we get started, I have a little bit of announcements that I want to get started, and this is mostly for those who are joining us for the first time. I know we get a significant amount of people that come in every week are new, so I just want to get this straightened out. So this call's going to be from 8 to 9 o'clock, typically about 1 hour long. And if you're looking for verification for your hours, you can write us a summary. A verification of hours, like why do you need that? Sometimes your school might require you to show that, like, to keep, to show that you've attended this call. So we do verify your call and send you a certificate. And if you want that, you have to write us a summary for about 3 to 5 sentences, nothing too fancy, just something that shows that you learned something and you took something out. That is the point of it. And you can send that to the email, and the email is clubmedshoot@gmail.com, and all of that details are posted in the bio. So if you go on to @officialclub on Instagram and click in the bio, all those details are posted. And if you have any questions during any time, you can always DM us on Instagram and we'll get back to you. And you can also watch the previous calls that we've had, but you can only watch the 2021 sessions, and the summaries will be due June 15th. That is the hard deadline, June 15th. Everything needs to be in by then. And we do ask that you just keep writing them together and you hold on to like the end and you just send them together. It's easier for us to just have one email and do them all together. Just works out a little bit nicer on our team. And please be patient in terms of us getting back to you. It can take us time. Like right now we're 1,000+ summaries backed up. So it takes us time. Give it about 4 to 5 weeks before asking us like how long is it going to be? It's going to be about 3-4 weeks, depends. Sometimes it can be earlier too. Some people get in within a week, but typically it takes a longer time just because of the volume that we've had recently. So yeah, please be patient about that. Another thing, we also have a volunteer section. So I know because of COVID, everything kind of got shut down. So if you're having difficulty finding opportunities to volunteer, check us out on Instagram @officialclub.volunteering, and everything that you need about how to sign up and the different programs that we offer are in the bio. So be sure to check that out. Without further ado, today we have a very exciting guest. Her name is Dr. Chan. She's a board certified radiologist out of LA. And her Instagram is @dr.chanmo. So be sure to follow her and check her content out. She posts a lot of great stuff. Dr. Chan.
All right, let's see here.
I'll stop sharing and I'll let you get.
All right. All right. Hello, everyone. My name is Tiff. My last name is Chan, just so you guys all know. I wish it was Chanimal, but that was just like a quirky, like Insta thing that I put. So I am a clinical professor in the Department of Radiology in LA. Today, I'm going to talk to you a little bit about what it's like to be an academic radiologist. Specifically, my field is in breast imaging, which is a fellowship within radiology, but I'll kind of give you like an overlook of everything. So I have a few goals for you today. I'm going to share with you a little bit about me and the journey I took to get to where I'm at. I want to give you a background in radiology as the awesome field that it is. I'll show you a typical day in my life, give you an introduction to the different types of imaging that we do, and I'll give you some examples of some cases that I see, including the disease processes and the procedures that I do. So I'm currently an attending physician on faculty at UCLA. I've been doing this for about 2 years so far, because right before that, I did my fellowship, which was also at UCLA as well, too. So this is my journey to becoming a radiologist with a specialty in breast imaging. Now, I'm definitely one of the less common people to have just gone through everything without taking any time off or doing any special programs. And for all of you out there who are considering applying to medical school, whatever stage you're at, just realize that there are a good amount of people who do take time off or who switch careers and that sort of thing. So if you're not coming directly from college, don't panic. I would say that you are probably in the majority. I had more of an idealistic idea of what medicine was. That's kind of like the disadvantage of kind of going straight from college to med school. But I'm also lucky, obviously, that I got in the first time. And if you did not, don't panic, or even the third time. Just make sure that you take that extra year afterwards to really boost your resume and do something that makes a big difference. Now, one thing I also want to point out too is that part of the diagnostic radiology residency means that you have to do an intern year, which is right in the middle here, an intern year in either medicine, surgery, or something called transitional, which is a combination of both medicine and surgery. This is kind of like our clinical year, and you get to choose which program you want to do. So, and you apply to them just like you do for the rest of residency. So I really love procedures and surgery. So I chose to do a surgery year exactly in the same place where I did my med school year. And I think it did help my technical skills and my overall efficiency when dealing with patient care. So what exactly is radiology? This is a really cool field that pretty much every other specialty depends on. From primary care to neurosurgery, all doctors rely on medical imaging to help them make decisions for their patients. And we aren't covered on a lot of medical shows. And when we are, it's usually a non-radiologist holding a picture upside down. But we're a very real doctor. And while many physicians feel okay reading their specialties imaging, such as orthopedic surgeons and reading knee MRIs, it is always kind of our responsibility to know more than them and to pick up on subtle or unusual findings. And radiology is basically reframing everything that you learn in medical school in the form of pictures. And these are just some examples of some types of radiology that we see. There's X-rays, MRIs, CTs, PET scans, angiograms, mammograms. The list goes on and on. And at the end of the day, the best part about this is that pictures present the truth about what's happening in a patient. And when medical technology advances, of course, so does radiology. So some of the older radiologists who've been doing this for decades are not as familiar, let's say, with CT or with MRI, but they're very good, let's say, at X-ray and ultrasound. So if you're somebody who's very interested in technology and kind of wants to be at the forefront of medical imaging, this is the field for you. I also want to point out that there are many specialties within radiology. And so these are just some examples of common studies you may have heard of and who reads them. So all these people here, these specialties, these are all people who've done the same residency, exact same training of that 4 years plus 1 year. And then they do an additional year or two in a specific area. So I'm in breast imaging, so I see a lot of mammograms, but somebody who, let's say, specializes in neuroradiology is going to be your go-to person for reading CT heads, MRI spines, and many, many other things. So we kind of divvy it up that way. And there are some myths about radiology that you may have heard of, and I definitely want to talk about it. So a lot of people, or some people, might think that radiologists aren't like real doctors because we're not running down a hallway shouting clear. But ironically, we are the only group that's considered the doctor's doctor. And so that means that physicians consult us for our opinion on their patient's imaging. And depending on our specialties, such as breast imaging or IR, interventional radiology, we actually have our own patients as well. So the myth that we don't see patients is not really true. During my training, like in residency, we would actually take call in the emergency room. And so when a trauma came in, let's say like a car accident, we would have to go to the CT scanner as they were scanning this person. And, most of the time these people are completely out of it, or they need to be intubated or whatever. So they can't give you like a really good history, which is something that is still important for any patient encounter. But the beauty of radiology is that we literally can just go and read a CT and we'll yell out findings to all the surgeons. We'll be like, hey, they have a spinal fracture, they have a kidney laceration, all these things that even if the patient was with it, they wouldn't be able to tell you really about. But we kind of find answers in the form of pictures inside people, which is really cool. There's also like this weird myth that we don't like to socialize. It's kind of funny because we work pretty good hours. So we actually have like more time to socialize like outside of the hospital. And I don't know if anybody actually thinks this. Radiology is actually pretty difficult, mostly because you have to learn everything from head to toe. Like all my training is learning imaging or medicine from head to toe, and that can be certainly very difficult. Our boards are for 2 days at, I think it was 8 hours each or something. So it's a lot of knowledge that we all have to know, regardless of our specialty. This is just something that I pulled off of one of our associations of university radiologists. It's a really great organization that kind of talks about academic radiology, not just breast, but academic radiology. And so these are just some things that they have noted. I know that they're taking away step 1 scoring, I think, in the near future, but just so you know, step 1 and step 2 scores, are, above average, like a moderate amount above average. Is nothing crazy, but it is competitive to get into, especially if you want to go to certain programs in, let's say, big cities. 18% are AOA members. People are very involved in abstracts, presentations, and that sort of thing. Once you get into the door, so these are all the things that, program directors care about when they're inviting you for an interview. So obviously your evaluations, your grade, your recommendation, those are all important. And then after that, it's really your interpersonal skills, because at the end of the day, we're going to be in the same room with each other, going over patient care things, asking each other for discussion, and going over cases that, we want to get a second opinion on. And we want to have good colleagues for that. So that's actually really, really important. So you may have heard of the road to success. I don't know if this is totally true anymore, but it's traditionally the 4 specialties that offer the best work-life balance. And that is kind of determined by this definition, by compensation and lifestyle. So I just wanted to put in this slide because radiologists are generally pretty happy and are compensated well. And by no means should this be a driving force behind what you go into. Because at the end of the day, if you hate what you do, no amount of money is going to make you happy. That being said, compensation was never talked about among med students or pre-med students, and it does have some practical significance. I started paying off, I've been paying off my loans little by little. So I didn't have like a huge amount by the time I became an attending. But certainly, I had over 300,000 in loans, and being compensated well helps me get through those loans so I can kind of go on with my life. So that is something that to consider, and it's always changing. It always depends on your location. This is just some overall stuff that you can think about. So not too bad in terms of earning potential, feel fairly compensated. And then probably the most important one, I would choose the same specialty. I mean, we're pretty like up there. So people are happy with this job. And of course we experience burnout like everybody else. But in the long run, I think that radiologists do pretty well. So let's talk about a typical day for me. So breast imaging is a specific field within radiology that's dedicated to the diagnosis and management of breast pathologies. So we use mammogram, which is a type of X-ray. This is an example of a mammogram. We use ultrasound, and we also use MRI as well. And we perform interventional procedures under imaging guidance specifically focused on the breast. So we do biopsies. So one question, why did I choose breast imaging? So I feel very fulfilled actually seeing patients. My ideal job is a mix of using imaging and clinical. So I want to see patients, and I love that my imaging, while it tells me the truth, is a representation of my patient, which I can also talk to as well too. And that's kind of why I got into medicine in the first place. In addition to that, I love procedures and working with my hands. And maybe that's because when I was a kid, I played video games. So I definitely needed a field where I was kind of doing that every day. And from a practical standpoint, if anybody's wondering, AI and outsourcing tend to affect fields a little bit less if there are, like hand-based sort of procedures. Just because the technology for AI doing procedures is just going to be harder to get to than if you were to do a job that's straight detection. So that was kind of a part of it that I cared about as well too. So what do we do? So we work in our own clinics, which is different than other radiology fields, okay? We spend some time in a dark room, maybe like 30%. And it's dark, by the way, because the eye can see contrast and therefore subtleties in pictures better when it's dark than when it's bright, like right now. But that's only 30% of my day. The majority of my time is actually spent talking about findings and recommendations with my patients. That means I'm telling patients, hey, everything looks good on your imaging. We'll see you in a year, come back. Or I'm telling them, hey, this looks really bad. I think we need to get a biopsy. So it's a huge range of conversations, and people obviously have different reactions to that. The other part of my day, other 30%, is doing image-guided procedures. So these are biopsies, these are drainages of abscesses, which are infected pockets of fluid that can happen. Cyst aspirations, where we're basically relieving a cyst, a little water balloon, by putting in a needle and sucking that fluid out. And we also do this procedure called a pre-surgery localization. So we work with breast surgeons to help target cancers. And I'll kind of go into all that as well too. This is a kind of average day for me that I have, and sometimes it's better, sometimes it's worse. But basically, I'm doing a mix of biopsies, localizations, diagnostic studies, which I'll talk about. And in the meantime, always reading screening mammograms and breast MRIs as well too, just kind of all throughout the day. Being in academics as opposed to private practice, I also teach residents and fellows. I give lectures like this. I give about 1 to 2 every 3 to 4 months or so. I'm also in charge of the resident curriculum here. So I help try to improve resident education. I think of innovative ways to teach things. So for instance, this is a synthetic breast model that we ordered. And this is to help residents learn and practice how to do ultrasound guided biopsies. As you can see, there's a needle here, ultrasound probe here. And I wanted to get this model because I felt that residents or fellows should be learning in kind of a low pressure environment before doing a biopsy for the first time on a patient, which can be stressful for everyone, including the attending, including the patient. So this was a great way that I learned in residency to work on my skills. So I brought it to my institution when I became an attending. On top of teaching, of course, I'm always looking to do conference presentations, abstract submissions, and getting published in journals as well too. So all the definitions of being academic. So who do we see in our clinic? So our patients are mostly women. They're technically of all ages, usually above 14. I've actually seen 98-year-old patients as well too, very healthy ones. So what you probably didn't know is that we actually also see men. So breast is not just like a woman thing. We also see men, maybe 1 a day. And they usually come to us with lumps or pain. The reason why we care is because males can actually still get breast cancer. It's not super common, but it does make up about 1% of breast cancers. And I've definitely seen a few cases throughout my few years here. More common, the things that we're trying to rule in is benign breast tissue, gynecomastia, and also benign fat tumors, which none of this becomes cancer, but it can certainly feel like it. And we need to get to the bottom of it. So we do see male patients. So what exactly happens in our clinic? So we technically divide our patients up into diagnostic, screening, and procedures. So I'll talk about the first two right now. So diagnostic patients are those patients that have a specific issue, whether it's a symptom that they have, a pain, lump, whatever. They're coming in for a follow-up of a probably benign finding that we had seen at another appointment, or they're here for what we call a callback from a screening. And so that's when somebody has undergone a screening exam, we see something abnormal, and we call them back because we want to look at it further. When they're here with us, they're typically getting mammograms and or ultrasounds, depending on the age and what we're looking at. We end up deciding on the management. So there's basically a few choices. You're either going to go back to screening, meaning, hey, everything looks good. We're going to want you to follow up in 6 months or so. This looks suspicious. I want to do a biopsy. Or in some cases, we may opt to do an MRI, which is more expensive and less comfortable for the patient. So we try not to do MRIs except for certain populations or to answer a specific question. And then, of course, the fun part is always once we make this management, we go and we discuss with the patient. So that's a big part of our day as well, too. And of course, the screening part, this is pretty important. These are patients that have no symptoms. OK, if they had symptoms, they'd be in this group. This means that they have no symptoms and they're just coming in for their yearly screening. And I'll go over all the kind of guidelines for that as well, too, because that's something that I can't do a breast imaging lecture without talking about real briefly. So at this point, you may be wondering what even happens in the breast. You probably have heard of breast cancer and cysts and not much else, but I swear there are other things. So this is just a brief overview of all the things that we see. And of course, I can't show you every single pathology, but there are a few things that I think that you guys can all take away. The first thing is that you can't tell if a mass is benign or malignant based on physical exam. So I have patients coming to me saying, hey, I have a lump here, but my primary care doctor or whoever thinks it's benign just on the way it feels. That means nothing. It's all based on imaging and how they look on ultrasound, mammogram, MRI, that sort of thing. And that's because things can be like squishy or hard or whatever. None of that really matters. And it's so subjective. So imaging, like I said, is kind of like the get to the bottom of everything. Other facts you should know: invasive ductal carcinoma, or IDC, is the most common type of breast cancer. You may have heard of that. DCIS is called ductal carcinoma in situ. This is considered to be a breast cancer and is treated as such, in case you ever encounter this term. And also, it's not just breast cancer that happens in the breast in terms of cancer. There are other things that can go to the breast. So there's lymphoma, melanoma, lung cancer, some of the more rare soft tissue tumors. All of these things can actually go to the breast as well too. So we're always on the lookout for that kind of stuff. Let me talk a little bit about screening mammography, some guidelines and kind of what happens. So you may have heard some different guidelines in the news, but we go by the ACR, American College of Radiology guidelines, because we're radiologists and we're the ones who see the cancers. So the general premise, by the way, for all screening exams, whether it's a colonoscopy or mammogram, whatever, we want to catch cancers in their early stages, and that's to prevent morbidity, mortality, and healthcare costs. If a cancer is advanced enough that a patient can feel it, we are obviously going to treat it, but we ideally want to find it when it's small and not causing symptoms. And therefore, our guideline is that in the US, of someone with average breast cancer risk, we recommend yearly mammograms starting at 40. And there's no end age because it all depends on someone else's health issues. So for instance, like I said, I had a 98-year-old patient who was very healthy. If she was a breast cancer, I would want her to get treated because I think she could handle it. Whereas there are some like 50-year-olds who have many other things going on. Whereas I'm not sure if breast cancer is their main priority in terms of things that they need to get solved. So that's why the age issue is a little bit, the age upper limit is a little bit not determined. Okay. I've also included some other statements here from the ACR about varying screening recommendations. The problem with delaying mammograms to when you're 45 or even 50 is that you're really missing a lot of cancers that present in their 40s. That's the general takeaway. Now, for high-risk women, and that means that you have a calculated lifetime risk of 20%. That's a number that you get from these risk models that you put your information into. Or for people who've had chest radiation for, let's say, another cancer when they were younger. For high-risk women, they do need to start a little bit earlier at 30. They also can get yearly breast MRIs. Certain groups, okay, should also have their risk at least evaluated, discussed at their OB appointment, at their primary care appointment. So they need to have that conversation at least starting early on. So what happens after a screening mammogram? So, 90% will be told that they have a normal mammogram. Out of 100, 90 will be okay. 10 will get called back for additional imaging. That's that diagnostic part that I was showing you. 6 will actually be totally okay. We were doing extra imaging and it actually turned out to be just some overlapping tissue, nothing to worry about, not going to be a cancer. 2% are going to be asked to come for a follow-up, and then 2% will be asked to get a biopsy or recommended to have a biopsy. Okay, so that's kind of what happens with all these patients. Let's talk a little bit about the imaging modalities that I go through. So this is the first one. So this is a mammogram. A mammogram is basically an X-ray, which is the oldest form of medical imaging. It allows us to see inside the body at a tiny, tiny amount of radiation. So each screening mammogram has basically two views. There's a craniocaudal view, CC, or an MLO, medial lateral oblique view. And I'm giving you some pictures of what this really looks like and the pictures that we end up getting. R is for right, L is for left. This is the machine itself. Ignore this guy in the back. This is the mammogram machine. The person's going to be sitting here and their breast is going to be here. This whole thing rotates. That's how we get this kind of diagonal sort of view, just so you know. So when we're looking at a CC view, there's some things that I have to show you. So I usually think of this as kind of looking down at your feet. So if I'm looking at this image, at the top of the picture is going to be my right arm, okay, my right side. And then over here is going to be my left arm, or actually it's really going to be my sternum, okay, because I'm looking at my right breast. Same thing on the other side. So that's the best way to kind of visualize what we're looking at here. And I'll show you some basic anatomy as well too. The lateral or outside part of your breast is where your arms are at. The medial is going to be, where your sternum is, and the nipple is going to be right in the middle. These are the same picture, just with some annotations on top. And this kind of vague thing you see in the back, that's going to be your pec muscle. That's the thing that people are working out on, that is in front of your ribs and your lungs and all that stuff. Essentially, when we look at a mammogram, what's white is going to be fibroglandular tissue, okay? And what's black is going to be fat, black as in dark gray. So the problem is that cancer comes from tissue. It does not come from fat. So when we're looking for a cancer, I'm looking for something that's abnormally white on this mammogram. There can also be fatty masses like lipomas, which is a benign mass, and that's going to appear the same gray as this. So let me give you another picture here. This is the MLO view, and this is kind of some annotations as well too here. This is a little bit easier to understand, I think. So if your nipple is here, your head's going to be up here, right? And your clavicles, your shoulder, everything's going to be up there. Underneath is going to be your upper abdomen. That's the best way to think of it. Here we can see the pec muscles a lot more easily. Okay, that's pretty cool. And we can actually see some lymph nodes in the axilla or your armpit area. And these are very important because sometimes breast cancer can go to them. Sometimes that's the first thing that we see. Or lymphoma can also live here, other types of cancers. And what we would be looking for is abnormally shaped lymph nodes that are very big. So like I said, we're talking about tissue versus fat. Tissue is white, fat is black. Maybe you've heard of this term breast tissue density. And so I just wanted to talk about this very briefly. Essentially, this is a thing that's determined by mammogram, not by clinical exams. It was determined by the radiologist. There are 4 categories that you can fall into. And this is the percent of general population that we usually see it in. So most people, 80% are somewhere in the middle. There are people who are more fatty in their breast, meaning that they don't have much tissue compared to fat. There's also people that are very dense, which is mostly tissue compared to fat. In general, density is related to genetics. You kind of are born with a specific type of density, not related to size as one might think. But there are some things that can increase your density throughout your lifetime. So as you get older, you actually gain more fat in your breast. It's actually your tissue involutes and becomes fattier. And then it gives the appearance that you have more fat in your breast. If you gain weight, you're gaining fat. So if that goes to your breast, then that's going to decrease your density. If you're breastfeeding or you're on hormone replacement, let's say you had a hysterectomy, your uterus is out for whatever reason, and you need hormone replacement for symptoms of like estrogen depletion, that's going to increase your density as well. So there are some things that can change your density. So why does breast tissue density even matter? I'm looking for, like I said, an abnormal white thing on a mammogram because cancer comes from tissue. So if I, the radiologist, am looking for something abnormally white on this person's mammogram, it's going to stand out, right? You guys see that little bunny. This is a different person, this patient in the middle. This person is much denser. There's more white than gray. I'm looking for that same bunny. It's a lot harder to see. And by the way, there he is. And that's because I'm looking for white on white. And that's why density is an issue as well, too. People with denser breasts innately are going to have a higher risk of developing cancer. So that's part 1. And then part 2, it's harder for us to find cancers in dense patients as well. So let's talk about ultrasound real quick. I don't know how much you guys know about it, but it's one of the old school imaging modalities. It's been around forever. The best part and the most important thing you should know is that there's no radiation, okay? And it's very useful for soft tissue in general. In fact, I used ultrasound the other day because I broke a glass like in my apartment, and which I like apparently didn't realize. And I almost stepped in it. And I had like a little incision, and I was very afraid that I had glass in my foot, which is like a legit, kind of concern. So I actually went and had one of my ultrasound techs help me scan my foot. And there's no radiation there, but it's soft tissue, and you can see glass on ultrasound. So I'm okay. There's no glass in my foot, but that's like a real life like application of ultrasound, for instance. Now, in the breast world, this is the first imaging test for women under 30 that are coming in with a breast lump or breast pain. Part of it is because mammography has radiation. Part of it is because mammography is less useful in young women who tend to have dense breast tissue anyways. And now this is not just some random guideline I'm telling you. This is all from something called the American College of Radiology appropriateness criteria. So no matter what you go into, even if it's non-radiology, you're going to be encountering this, okay? So this is basically an organization of American College of Radiology, and it's a guideline to help you decide what is the best imaging test for your clinical question. So this one is for this specific question, somebody with a palpable breast mass. This is a female who's younger than 30. What do we do first? This organization gives a rating from 1 to 9, with 9 being, hey, this is what you should be using, and 1 being like, don't use this exam as your first thing. So they have different, what we call variants. So even if you're looking for like chest pain, you're like, what should I order for this person? Or vaginal bleeding or whatever for different age groups, this appropriateness criteria down here, you can find it, will have basically guidelines on what sort of imaging to start with. And ultrasound breast is the first one for someone that's young. When we talk about breast ultrasound, we like to scan our patient in what we call the supine position. I was taught to remember supine like soup, like you're holding something like this. Prone is the opposite, it's where you're laying on your belly. And so when I show you this sort of picture, you have to orient yourself to this. This is an ultrasound picture. You think about the top of the picture being where the probe is placed, going down like this. And this is the breast tissue. And this is the back of the patient, the chest wall. Okay. This is actually a rib. So during these biopsies, we try to stay away from this general area. We stay like from here and below, we do not want to go near. This is all breast tissue. This is our territory if we wanted to biopsy. Okay. Last imaging modality I can talk about before we do some cases, breast MRI. The patient's actually positioned prone on their belly with their breast kind of hanging through a window. And this seems kind of weird, but we do it because gravity is pulling down the breast tissue and we can see more of it, as opposed to a CT scan where the patient is supine and the breast is basically compressed and we can't see as much in the tissue. And in fact, we don't really recommend CT for looking at breast tissue. Sometimes we catch things, but it's just not reliable enough. Okay. So who needs a breast MRI? Because it certainly is not everybody. This specific study is needed for high-risk patients, silicone implant evaluations, and specific groups of people that, let's say, have had biopsy-proven cancer. They know they have a cancer on one side, but the surgeon's like, hey, I want to know if there's other areas that are involved before I take this person to the OR. So we need to establish extent of disease. And also patients who've already had breast cancer and surgery, and we're concerned that their cancer has come back or not, not all of the cancer was taken out. This is an example of a breast MRI. This is the right breast, this is the left breast. Heart, right lung, left lung. These are implants, which is kind of cool. So I will show you a little bit more of that later. Let's go through some cases. So this is a very typical case. So this is a right mammogram. This is a 56-year-old patient, and she's coming in with a dense patch of tissue on her superior breast, upper part of her breast. The thing I have circled here is actually a little metallic BB marker. This is something we actually put onto the patient. And that's because she came in with a lump. She said, hey, this right here has been bothering me. It's a bump here. I've noticed it for the last month. So we put a BB there. And then when we do our mammogram, we can see that marker very well. And we kind of tune in a little bit more to that area. It's not like we ignore the rest, but we really want to look specifically at that area. What we see here is this dense patch, very white, that looks different from the rest of her tissue, right? So then we go to ultrasound. This ends up showing an irregular vascular mass. And then we want to do a biopsy. This looks very suspicious. And this actually came back as an invasive ductal carcinoma. In case you have not seen too many ultrasounds, by the way, this like crazy red stuff, that's a program that we kind of put onto the ultrasound. And basically anything that's moving is going to turn red. So it's an artifact. It's not actually like red inside, or yellow, but it's like an artifact that we put on to show things that are moving. And the key is that the only things that are moving is going to be blood flow. So this is a picture of blood flow. This is showing that there's vascularity going into this mass, which is a more suspect sort of finding for any cancers, because cancers grow as tumors when they are recruiting blood vessels to themselves, getting more oxygen so they're growing. That's how tumors grow faster than other parts of your body. So anytime we see an irregular mass that is also vascular, we definitely want to get a tissue sample of. And by the way, masses, when I use that term, is a 3D space occupying structure. It's not necessarily a bad thing, okay? Because things like cysts, which is a benign like water bubble in your breast, is technically benign. A benign breast mass, such as a fibroadenoma, is also a mass. So the term mass is very scary, but technically it just means it's a 3D space occupying structure. How we determine if we want to look more closely at something is just depending on the shape, the margins, and that sort of thing. And along with that, we recommend that patients know how their breasts feel at baseline, but we actually don't recommend specific guidelines on self-breast exams anymore, like we used to. There's increased false positives, meaning people are panicking all the time. They're coming in and it's actually, just some regular breast tissue. And it increases patient anxiety as well too. Second case. This is a demonstration of how not all masses are bad. So this is an 81-year-old female who is on blood thinners or anticoagulation. She's on this because she had a stroke before, which is basically a clot in your brain. And in order to prevent future strokes from happening, she now takes a medication that makes her blood thinner so it doesn't clot as more easily. So she's coming in with a breast mass. This looks very weird. And we do an ultrasound. Now, if you've seen enough ultrasounds, you can tell based on this that there's actually more fluid than solid. So all this really dark stuff here, that makes you suspect that there's fluid, okay? There's like maybe a little bit of vascularity, but nothing too crazy. So because this looks like fluid, what we ended up doing was putting in a needle with lidocaine. Of course, we do some numbing medication. We put in a needle all under ultrasound. That's why we're radiologists. We put in a needle and we pull back and we actually get all this bloody red liquid. So this is actually a hematoma that formed in somebody who was on blood thinners. The beauty of blood thinners is that while it does prevent strokes and other bad things. That's why people are on it. But also it can make you bleed a little bit more than you would otherwise. This is not very common in somebody who's not on blood thinners. And by the way, this patient didn't have any trauma. She doesn't remember falling or running into the door or getting punched or anything like that. She was just living her life and this ended up happening. So this is a good mass in the sense that it's not a cancer, but it's something that we also see. Now, let's talk about a 29-year-old female who comes in with a left breast lump. And so first question is, of course, what imaging study should she get? And it's going to be an ultrasound because she is under 30. And this is her target ultrasound right over that lump. Okay. So what is this thing? That she's like, okay, it's definitely this. I'm super worried. I think it's a cancer. My mom had breast cancer when she was 45. What is happening? So it's so tricky actually, because this is actually just your rib. This is a normal ultrasound. Your skin is up here. Your breast tissue kind of by these blue asterisks, that's all we were looking for, masses, cysts, etc. Your pectoralis muscle is going to be that striated sort of looking thing that's draping over your rib. And underneath is going to be your lungs, which we stay away from. So it's kind of cool because on real-time ultrasound, you can see somebody breathing. So their lungs are going to go up and down. The rib is sometimes felt if somebody is very thin. And it can be very concerning. And we always want to look and make sure. But that is something that we can see. And that's also a normal thing to feel. Let me talk about calcifications before we talk about our next few cases. So these are very common in the breast. The biggest difference between calcifications here and elsewhere in the body is that sometimes they can be associated with cancers in the breast, okay? Now, they're not necessarily bad. Having them is not necessarily a bad thing. We, as radiologists, our job is to look at their shape and their distribution to determine whether we need to follow something, let it go for a year, or biopsy. Some of them are 100% benign. We don't even follow them at imaging. And, the older that you get, the more calcifications you tend to have. If I was to do a mammogram on someone in their 30s, I don't know if I would really anticipate seeing many calcifications. But someone who's 80, sure, I would probably see it in a completely healthy, cancer-free person. Okay. So let me give you some examples here. So this is a 65-year-old female who came in for her screening mammogram. And as you can see, there's all these like crazy zigzag things everywhere. So they're bright white lines, and these are actually vascular calcifications. I can tell because they look like they're forming in tubes. And the term is called tram track, meaning they look like this. They're kind of like lining the tubes like this. Okay. This is a benign finding. Interestingly, if she was younger, if she was 41, and she came in with the screening mammogram, I would have to wonder if she was a diabetic or if she had kidney problems, because that's the only reason why someone young should have these sort of issues, these vascular calcifications. Totally normal in an older person, but a young person like really shouldn't have them. So sometimes we bring into light other issues that a patient may not really know about, which is interesting too. On the other hand, these are very suspicious calcifications. Now, I don't expect anybody to necessarily definitely see the difference between the two, but you should be able to tell this is a different shape than what we just saw previously. This is what we call fine linear branching. They're in the shape of ducts, and we call it back. We do biopsies. We do biopsies, and this is something that's DCIS, which is treated like a cancer. So just a big range of the different types of calcifications we see. By the way, patients cannot feel this, all right? This calcifications do not cause a lump. They do not cause pain. They are a big reason why we need to do screening mammograms, even in patients who are like, oh, I don't want to be compressed. I just want to get ultrasound. You should be able to find things that way, right? Calcifications, you can only really see on mammogram. Let's talk about breast implants. Okay. So I'm in LA, so we see breast implants all the time. And there's two general types of implants, silicone and saline. And just so you know, patients with implants often think that because they have it, they can't get mammograms, which is like not true. Our technologists actually are able to displace the implant so we can only see the breast tissue. They do these special methods to displace the implants, and there's really like a 0% chance of rupture. I think there's some in the literature, but I suspect that these are implants that were old and probably were like about to rupture slash already had ruptured, because I haven't really seen any de novo or new ruptures during my time, okay, even as a resident. So the basic story is that mammogram is still very useful in these patients. The only issue is that implants may make it a little bit harder for biopsies if this person needed a biopsy, because now I have to really make sure that I don't go anywhere near the implant with my needle. I don't want to cause an implant rupture. Okay. And this is what an implant looks like. This is definitely on the larger side. But in case you wanted to know what a breast implant looks like, that's what it is. Okay, so next case. This is a patient, who's worried about like breast implant ruptures. Like I said, there's two different types. There's silicone and saline. This is an example of saline implant ruptures. They should be nice and full, right? Like we kind of saw that before, like they look like an implant. This has already deflated. Now, the interesting thing is that saline implants, when they're ruptured, you can tell on a physical exam. You don't need us to tell you that. If anybody has ever seen Orange is the New Black, there's a scene where I think someone gets like punched in the breast, and then like her implant just completely like deflates. That's a saline implant. Like I can just tell from that episode, because a silicone implant, if she was punched, you're not going to be able to tell on physical exam. And that's because silicone implants are a lot gooier on the inside. They're very viscous. So there's a lot of people walking around out there with ruptured silicone implants, but you can't really tell from the outside. Okay. And those are the people who need imaging with us. This person happened to get imaging because she didn't really want to get these fixed. She knew about it, and this was her screening mammogram. So that's the only reason why this was done. Silicone, by the way, when we're looking at these implant ruptures, is best seen on MRI, sometimes the other studies as well too. Last thing I wanted to go over with you guys was my favorite part of what I do, the image guided procedures. So we do, a few different types of procedures in our office. They all involve local lidocaine, kind of like the dentist's office, no general anesthesia. So I like telling my patients that they can eat whatever they want, they can drive themselves, they're going to be comfortable during the procedure. The main, procedures that we do is going to be a biopsy where we sample a piece of tissue. It obviously looks suspicious on imaging. So our job is to get a good sample of that tissue. We send it to that other doctor, the pathologist, and we get our results in a few days. Localizations are for surgeons. We are pinpointing a cancer for surgery. And I'll go into that a little bit as well too. Abscess drainages and cyst aspirations. And this is a very typical kind of procedural tray that we have. And I kind of labeled all the stuff that we use. This is our biopsy, one of our biopsy devices. So let's say that we're talking about an abscess drainage. So this is a 26-year-old with a left nipple ring, and she came in with like this red bump underneath her nipple. It's not responding to antibiotics. It's super painful. We do an ultrasound, and it looks like a big infected pocket of fluid. Just this is the appearance of an abscess. It looks ginormous on this screen, but it's really only about 4 centimeters. Okay. There's focal breast redness, there's pain, and this needs to be removed. Okay. All this fluid needs to be removed. Just so you know, a similar procedure is a cyst aspiration, and that's done for symptomatic relief. So what we do, and I'll give you kind of an idea here, is that we give her some numbing medication, we put in a needle, and we take out that fluid. And what happens is this. So this is all the stuff that was inside her breast. There's a little bit of blood that's in there, and then everything else you're seeing is basically pus. So this is an abscess that the patient would not be able to get rid of. Like her body would not be able to get rid of it without an intervention. No amount of antibiotics is going to help her. A small abscess, yes, something around this size just needs to be decompressed. She needs to get that stuff out. And if she doesn't, okay, it can become systemic. She can develop fevers. Her white count's going to go up. It can get bigger. There's a lot of bad things that can happen. Okay. But this is a really cool kind of acute procedure that we do. I'll talk to you a little bit about these pre-surgery needle localizations as well. So the terminology here, if somebody has cancer, okay, breast cancer, there's kind of 2 surgeries that they could get. A mastectomy is where the surgeon removes the entire breast. A lumpectomy is where the surgeon removes only the cancer. Okay. So it's really great. It's something that, hasn't always been around. A lot of the times in the past, people have gotten all mastectomies. But with lumpectomies, the tricky part is that they need some guidance on exactly where that spot is, because their goal is to take out all the bad stuff not take out too much good stuff, and not leave any bad stuff behind. That's really the premise of everything. So what happens here is that this patient was already diagnosed with a cancer. This is a small clip that we leave behind, that little white rectangle. She's coming in for surgery. The surgeon's like, hey, I know it's in the upper part of the breast, but I need you to tell me exactly where it is. Because if you think about it, the breast is like a sphere, right? So they need help and guidance exactly where it is. So what my job is that I see this patient the morning of the surgery, and we put a needle right down to that area. Okay. And that's the needle that you see here is this one. And what that does is it helps guide the surgeon exactly to that area. The patient's then going to go to the operating room with this needle, and the surgeon's going to use that wire to take out the cancer. It's kind of like it's right here sort of situation. Okay. And if you want to see what it looks like officially, this is the specimen that's sent to us right after the surgery. The patient's still under, in anesthesia, but they want to make sure that they took out everything that they needed before they close up the patient and put her in post-op, in the PACU. So this is sent to us, and our job is to say, hey, that rectangle which marked the cancer, it's there. You got the right area. And we check to make sure that basically the cancer's in the specimen. And that helps ensure that the surgeon got the right tissue before the patient gets closed up. And this is what it looks like in real life, by the way, guys. This sample, it's rainbow colored. Obviously, your breast tissue is not rainbow colored. These are dyes that the surgeons are putting on and the pathologists are using to kind of demarcate its orientation in real-time space. So they may say, hey, whatever's marked in blue is actually the inferior part of the patient. Whatever's marked in orange is, the more medial part. So that's how they kind of reorient things. Because if this clip or the cancer was at the edge, like over here, I need to tell them, hey, you need to take out more tissue in this particular area. So that's how we kind of talk to each other. And this is what it looks like in real life. An x-ray of this is going to look like this. And in this particular case, we see that there's a marker here, the wires here. And this is what one of the wires looks like in real time as well, too. So it's a pretty cool procedure. And we work very closely with surgeons about that. And I think that's kind of all the cases that I have for you guys. Thank you for joining me today. I hope you guys learned something about radiology, maybe about breast imaging. Feel free to message me with any questions. You can always DM me, follow me, whatever. I'm always available to help you guys. So I hope you guys learned something.
Yeah, that was awesome. Thank you so much for going through that. I have a small question. In case 8, you said, lumpectomy, you only take out what the bad part is, just the cancer. How often, in how many cases do you see when you do that, the cancer actually comes back again?
It's not that common. I mean, certainly, the more advanced cancers, I think, like historically, are the ones that are more likely to recur. And of course, there's another whole aspect of this cancer treatment I haven't even talked about, which is chemotherapy, right? And radiation. So in people, there's certain people that when they have a certain subtype of cancer, if it's really, really bad, they tend to do all that other stuff before they come to surgery to really kill off like any additional sort of cells. So we do everything in our power, like as a group, like us, radiation oncology, medical oncology, surgeons, to prevent any residual disease from happening. So it's a pretty low number if everything is checked off correctly from the start. If the pathologist does a good job with the subtypes, which they always do, and we hook them up with the right sort of treatment before, generally the margins are going to be good. So we usually don't worry about it too much, but it can happen. And certainly the issue with breast cancer too is that it's a lifelong problem. Okay. So even if you get treated and you're disease free, it doesn't mean that in like 10 years or so, it can't recur. And it might recur in the same breast or the different one. So that's definitely a sad part about breast cancer. But the good overall news is that if you detect it early enough and you do mammograms and you're kind of aware of how you feel, you are able to kind of detect it early, then your, lifetime mortality, morbidity, all that stuff is actually pretty good. So that's why we do what we do.
Gotcha. Thank you so much. Thank you so much for coming in and talking about all that. I think that was really interesting, and a lot of people in the chat are thanking you for taking your time. I'm going to ask you one last question before I go out. From Whitney, how early do you recommend someone begin receiving screenings if they have a family history of breast cancer?
So it kind of depends. You need to have that conversation a little bit earlier. You can start in your probably 30s. And it's going to be interesting. It's going to be, if you truly are high risk, there can be a combination of screening mammogram and MRI. So each one's going to be done like yearly, but kind of like this. So like if this is your screening, right? And then this is your MRI, you basically have something to do every 6 months, but they're kind of adjunct to each other. Something like MRI, we don't recommend for screening for an average risk person because it picks up a lot of false positives, things that end up undergoing follow-up, biopsy, et cetera. They don't have as much meaning in an average risk person compared to a high risk person. So that's also something that's different in high risk people as well too. So generally in your 30s is definitely sometime you could think of too.
Okay, gotcha. Again, thank you so much, guys, for coming in today. Before go out, just a couple more things I want to say. If this was the call for you, awesome. We'll continue to have call. I know we didn't have one last week because there was a last minute cancel. The doctor had something come up, but we'll continue to have calls like every week, like we've had so far. So be sure to check us out and ahead of time to know what you want. And you can also sign up for email reminders through the link in the bio, which we send out weekly ahead of time, so you know which doctor's going to be coming in and what they're going to be talking about. So that's really, really neat. Again, thank you so much. Thank you so much, Dr. Chant, for coming in and